Are we ready to talk about spinal cord injuries? So your lovely spinal cord right here. All right, your objectives for this PowerPoint, you can read them at your own desire. All right, so spinal nerve. So how many vertebrae, cervical vertebrae do we have? 7. Throughout this PowerPoint, you will see C8. Why is that?
Nerve.
A nerve. Okay, so why? Why do you have 8? So your C1 through C7, they're above the cervical, and then and then your C8 kind of innervates underneath. That's all you need to know about that. You don't have to go into depth. I just want you to be aware of there's not 8 cervical vertebrae, but there is 8 cervical spinal nerves. Thoracic, you have 12 thoracic vertebrae, you have 12 thoracic spinal nerves. Lumbar, you have L1 through L5, and then you have sacral vertebrae S1 through S5, and then your coccyx or your butt bone. So who can tell me what this is? Question.
I was just going to say, I learned that you eat breakfast at around 7.
Yeah, that's the next slide. You're beating me to it. All right, what is the dermatome? Yeah, so basically it's a skin receptor. So I did a neurosurgery rotation in my nurse practitioner program with this great surgeon that I hope you all will get to work with. But if you have an injury at kind of these C levels, you're going to have injuries in these dermatomes. So in these thoracic, you're going to have injuries in the thoracic area. And then your lumbar, you're going to have injuries in these legs, toes. So a little backstory story. I was in a motor vehicle accident when I was 16 and had a spinal cord injury. I had injury at my L5S1. So right here. And I had, so if you look at these dermatomes, I have the perfect numbness, tingling, everything in my foot. So these dermatomes kind of given to you, like where your extent of your injury is where you're going to feel that numbness and tingling. Questions, concerns about that? So with these cervical injuries, I learned this funny little acronym and it helped me. So I'm a server at a restaurant and I have a plate in my hand. So my bicep right here, so I have a plate in my hand right here. My bicep is my C5. So I'm a server, I have a plate. I'm handing my tray. So that's my triceps. And also my brachial plexus. That's my C6. So C5, I got my plate in my hand and I'm working my bicep. That's my C5. C6, I'm giving you my tray. So that is my tricep. So that's your C6. Your C7, so you're extending, that also plays into your C6 as well. So that's your tricep and then your extension. Your C8 is your finger flexion, so I'm taking your money. And then your T1 is just like you're throwing the money away. So basically it's like that motion, if that makes sense. No, but it helps you with these injuries when you see it in the clinical setting, if these patients are complaining, because you're going to see a neuro assessment being performed, and they're going to have a high C injury, and they're going to be like, oh, give me elbows, check my flexion, bicep curl, tricep curl. And so it's good to know at the extent of the injury. And there's a video I'll post after in the module, and it's just fun knowledge. I feel like it helps you also when you're studying to be able to understand this. All right, here is what he was talking about, your levels of your spinal nerve. So this is your spinal nerve. So this is why I don't want you to get confused. There's 8 cervical nerves, but 7 cervical vertebrae. I want you to make sure you understand that, which I know you guys do. 12 thoracic vertebrae, and then 5 and 5 of your lumbar and sacral. So your cervical without even knowing, just kind of knowing your baseline knowledge, if you have a high cervical injury, you're going to have more damage, correct? So your cervical controls your diaphragm, your chest wall muscles, arms, and shoulders. So if you have a very high C injury, cervical injuries like C1, C2, these patients more than likely are going to have diaphragm and chest wall muscle paralysis. So with that being said, these patients, you already know just based on your anatomy that these patients are going to have probably vent dependent if they have a high spinal cord injury. Thoracic, so your rib cage area basically. Controls your upper body, your GI function, so depending on where your injury is, depends on if you are paralyzed or not, wherever your injury is. And then your lumbar, sacral, typically this is your lower body, your bow, and bladder. So sometimes with these patients, when it's very bad, these lumbar vertebrae, it's compressing the nerve endings, and they lose complete paralysis and bladder function. So basically just you work your way down. So a higher cervical injury, paralysis all throughout. Thoracic kind of just depends on when your injury is, and then lumbar is typically just lower extremities. All right, this is a big fancy slide that you guys will not have to memorize, but like I said, if you work in a neuro floor, it's important for you to know if you have an injury at the C1, C2, C3 level, where you're gonna be injured at. Same with your L1 through L5, and then your T1 through T12, but you do not have to know this slide. It is way out of your scope of practice, way out of my scope of practice. I'm not a neurosurgeon, so you don't have to know it, but it's a good information. So spinal cord injury. So there are several mechanisms of injuries that can occur. So hyperflexion, so just based off what flexion is, you can tell me what flexion is. Towards your body. So this is most often in your cervical area. So if we're going towards our body, we have hyperflexion. What type of injury, mechanism of injury is this typically? So it's typically a head-on collision, so you're going like this. So it causes cord compression from fractured segments. We'll talk more about this, but when you have hyperflexion, a lot of these patients will break these vertebrae like high up in the cervical region. Hyperextension, so what's extension? Yep, so backwards. So backwards and downward motion of the head. So hyperflexion, you're going towards the chest body. Hyperextension, you're going away from the body. So these are often seen when you're rear-ended, because when you get the impact of a rear-ended accident, you go backwards. Or motor vehicle collisions. Spinal cord is stretched and distorted. So sometimes when you're stretched and distorted, it can be actually worse than a fracture. Because you stretch, you have ligaments all surrounding these neck tissues, and you can stretch these. And it's very unfortunate for the patient if they stretch a specific ligament in their neck. And then rotation. So, what's rotation? Yep. Yeah, so we'll talk about, we can talk about, so a DAI is this is way in, but a diffuse axonal injury. So when you hyperflex and hyperextend, you get shearing through your brain, and it's caused by your hyperflexion and hyperextension, typically impact. And then your rotation is just a combination of the two, which also goes into the diffuse axonal injury, which is your DAI that you learned last week. Severe rotation of the neck or body results in tearing of posterior ligaments and displacement, rotation of the spinal column. So these patients, out of the three, this rotation, it causes complete disruption of the ligaments, the dura, and it causes fracture. So it's pretty bad if you get a rotation injury. Axial loading or vertical compression, you will hear these in the hospital as compression or burst fractures. So that's how you will hear these labeled typically. So burst fracture or a compression fracture, and it's pictured right here, so you can see how it's compressed basically. So it occurs from vertical force along the spinal cord. It is commonly seen when you have a patient that falls. So falls from a height, because when they fall, they try to catch themselves. That's just their natural body response, and the compression cracks that vertebrae. And these vertebrae, let me tell you, these vertebrae are very, very strong. So it takes a lot of impact to break them. So like I said, these axial loading or vertical compression, you'll hear them as burst fractures or compression fractures. It sends bony fragments into the spinal canal or directly into the spinal cord. So these patients typically, if you have this type of injury, they will have to go to surgery to get it stabilized. And we'll talk about all that kind of treatment for it later. But sometimes they have to get this whole entire vertebral body taken out, cleaned out, and then they actually have to just get a whole metal rod basically that acts as a vertebrae. That's called a corpectomy, which you will talk about that in a minute. And then we have penetrating injuries. So just like our penetrating chest, you can have a bullet, knife, or penetrating object. It can cause permanent damage, or it can also transect the spinal cord. So let me tell you guys, I had a patient who got shot from behind, and it transected his whole entire thoracic cavity. The bullet went directly through and through, and he was there was nothing they could do about it. There was, like, as soon as the initial bullet went through, he was transected, and there was no fixing that. So if you get shot in the back and it hits just perfectly, these patients typically end up paralyzed wherever they're below the extent of injury. All right, so do we understand our mechanism of injuries? Basically, you can flex, extend, rotate. Anything, any direct cause to the spinal cord can cause an injury. And most of these times, these injuries will occur from trauma. And you can be assaulted, but that's trauma as well. All right, there is several types of spinal cord injuries. Oh, so this SCI, in case you guys didn't know, is spinal cord injury. I don't want you to be thrown out of the loop. So they cannot be classified until spinal shock has resolved, which is typically within 1 week. So a patient comes in initially and they have some sort of paralysis and they get intervened or fixed. You can't classify them until 1 week typically after, because of the swelling, the trauma. You don't know what's going to be like baseline versus what's going to be residual. So that's why I say you cannot claim a patient is quadriplegic initially. It typically has to be within 1 week. So you have complete injury, which is what I told you about that gunshot wound or the gunshot victim. Complete dissection of the spinal cord, total loss of both motor and sensory function below the level of the injury. So wherever you get injured at, below the level of injury is where you're going to get, where your paralysis is going to be. So that goes back into your dermatome. So quadriplegia or tetraplegia, I'm sure you guys are very familiar with these terminologies at this point. So again, I don't want you to get confused by this C8. This just means C8 nerve. You only have 7, correct? Paralysis to some degree in all 4 limbs. So I've had patients that I have resolved, so their spinal shock has resolved, but they are quadriplegic, but they have some sensation still. Like they can kind of shrug their shoulders or like move their hand, but typically that's the extent. Paraplegic, so this is where your thoracic to your lumbar. Paralysis of your lower body and legs. They may have full use of their arms, so they might be able to move, have that fine motor of their hands. Remember, the lowered cervical is your fine motor of your hands, so they could have that depending on where their injury is. If you have a C8 nerve injury, you could have some fine motor, or you could have some deficits in your fine motor in your hands. So it just depends on what your injury is. They may need a wheelchair because they cannot move their legs, so they're paraplegic. And then there's 4 types of this incomplete injury. So on an exam with this incomplete injury, which we'll talk about them, but I just want you to be able to differentiate the 4 types and how a patient might present. So there's if any motor sensation function remains below the level of injury. So there's 4 types. So the first type, Brown-Séquard syndrome. So this red, pink, yes, I guess it should have red on your screen. This red pink area is your damaged area. So like I said again, for these incomplete injuries, I just want you to be able to know how they would present and how you would be able to identify a patient if they had these one of these four types of incomplete injuries. So damage to only one side of the cord. So see right here, you have one side of the cord. This is your cord, central cord right here. You have your white matter and your gray matter. You don't have to go into much detail, but of course it monitors your sensory and motor. So you have damage to this one side, so this pink is your damage. You're going to have loss of voluntary motor movement on the side of injury. And then you're going to have loss of pain, temperature, and sensation on the opposite side of injury, and that's because of what your spinal cord does, how it innervates. So, Brown's or quad syndrome, you're going to have damage, motor movement on the side of injury. They're going to have loss of pain, temperature, and sensation on the opposite side of injury. And as you can see on this, he's got one. He's hit this one side, has damage to it. Central cord syndrome. So basically how it's typed out and said is what it is. So your central cord right here. It's typically associated with your cervical hyperextension. So hyperextension, hyperflexion. So injury. And hematoma formation in the center of the cervical cord. So on CT or MRI, you can see a patient have a giant hematoma, which is just a collection of blood bruise on the inside of your spinal canal. This produces a motor and sensory deficit that is greater in the upper extremities, so your central is your upper extremities and your lower extremities. All right, so this is type 1, your Brown's quad. That's your motor movement on the affected side, loss of pain, temperature, sensation on the other side. Central cord is you're going to have motor and sensory typically in the upper region compared to the lower region. So those are your 2 out of 4 types of incomplete injury, and it's demonstrated by this picture right here. Then we have an anterior cord syndrome and a posterior cord syndrome. So your anterior cord syndrome, so highlighted is the posterior component of the cord. It is associated with injury to the anterior gray horn cell, so your motor, your spinothalamic tract, so your pain perception, and then your light touch. So all those sensory type things as well as your motor. So your anterior cord syndrome patient, so anterior of the cord, they are going to have loss of motor function and pain, temperature, sensations below the level of injury. So if I have a T1 injury and I have an anterior cord syndrome, I'm going to have below that level. I'm going to have this loss of motor function and pain, temperature, sensations below my T1. If that makes sense. While position, sense, and sensations of pressure, vibrations remain intact. So that's your anterior cord syndrome. Now you have your posterior cord syndrome, which is highlighted right here in your posterior region. This is typically associated with hyperextension injury with damage to the posterior column. So of course, if you have injury to your posterior vertebrae, you're going to have injury to your posterior cord. So they're going to have loss of position, sense, pressure, vibration below. So your anterior cord, they'll have that intact because their posterior cord is not affected. With your posterior, you're going to have your motor function and sensation that you lose in your anterior, but you're going to have that loss of position, sense, and pressure. So basically, it's just opposite, the two, because you have this is what your anterior and this is what your posterior does. So I just want you to be able to know that how to identify these patients and what their deficits would be if they were to present with this type of injury. And if they have, so if it's associated with a hyperextension injury, and if there's damage to the posterior column, you guys are going to be able to say, oh, he's got posterior column damage, he's probably going to have a posterior cord syndrome damage as well. And that's just going to take studying and understanding those terminologies, but I believe in you guys. And then here's just a simple way to put it. The highlighted region is the affected injury, or the affected side. So you have your Brown's quad, anterior cord, posterior cord, and central cord. So just make sure you know the difference and how they will present.
Can y'all combine these with our infrastructure? Can y'all combine like questions like, for example, like citrus syndrome could be caused by subarachnoid hemorrhage?
So subarachnoid hemorrhages, brain.
Okay.
We wouldn't do that. Yeah, we wouldn't do that to you.
Okay.
Yeah, no. You're thinking into the weeds. Like you made, I know. You made me question. I was like, wait, what? No, I will not give you a patient that has a subarachnoid, and then I'm like, oh, this patient has also a C1 injury. What spinal cord injury are they gonna have? We're gonna do that to you guys. Oh, and by the way, they're in DI. What am I gonna do? And then there's like all 4 answer choices are the correct answers, but you have to choose the best correct answer, right? Priority, and then you guys after the exam are gonna be like, oh, she really did have that mean professor vibe on the day week before Halloween. Okay. Again, so quadriplegia and paraplegia. So I thought this slide was pretty interesting because quadriplegic, if a patient becomes quadriplegic, so as you can see, that's typically associated with your higher C level injuries. Average lifetime cost is $1.35 million in healthcare costs, which I didn't realize it was that much. And they usually stay in the hospital for 3 months, which that kind of makes sense because these patients simply need very extensive rehab and resources. But that $1.35 million cost. Oh yeah, well we'll talk about that. A lot of these patients go into neurogenic shock and the blood pressure, respiratory stuff, everything just crashes. But yeah, $1.35 million on lifetime costs if you are quadriplegic, and so that's very sad. So these C1 through C7, you have 8 cervical nerves, so just be mindful of that. And then you're paraplegic. If you're paraplegic, it's still $500,000 on cost. I thought this was also interesting too because 82% of spinal cord injuries happen to males. Why do you think that is? Yeah, because they're brave. I don't know if you look right here, but 48% are motor vehicle accidents, and I don't know about you, but I have a younger brother, so I can vouch for him. And he has a Camaro, so he likes to drive extremely fast and reckless, and it makes me sad. But teenage and males and older males like to be little race car drivers, so that's why you'll see 82%. This also goes to tell you like where your thoracic or where your level of injury, what might be affected. I'm not gonna nitpick until, oh, you have a T1 fracture, what's going to be affected. I'm not gonna do that to you guys. So here's just a little picture, paralysis, quadriplegic, so he's all shaded out from the shoulder down. But he might have some shoulder shrugs because he's still got a little bit of deltoid right there, kind of. Paraplegic, so you know that's below the waist, and hemiplegia, that's halfway. Which syndrome would this be? Yeah, Brown's quad and stroke, the stroke too. Again, this just kind of talks about your injury level and resultant functional loss. So kind of like where you're, like how I said, your higher injuries will be quadriplegic, your thoracic typically going to be paraplegic, and then your lumbar is going to be typically paraplegic. It just depends on where you lose your function at. Quada equina, what is that? Yeah, it's a horsetail. It's like I don't know if you've ever seen it. It's just basically a little of like nerve innervations, and it looks like a horsetail of nerves. Typically, if patients have injury to this quada equina, they will lose bladder function. All right, spinal cord injury. So you have paralysis below the level of the injury. So injuries that are above your C4, typically you're going to have paralysis of your diaphragm. It kind of depends on patient scenario, but typically we have it higher because C1 through C5 is you have the innervation with your diaphragm. So typically the higher cervical injury, you're going to be quadriplegic. So higher the injury, greater the loss of function. Yes. So remember, C3, C4, C5 keeps the diaphragm alive. Why? There's a nerve that innervates it. What is the nerve? You might not know. Phrenic. Yeah, you guys know. Good job. So the phrenic nerve is what innervates, so that's what helps your diaphragm. So with these patients, I'm not saying that if they do have a C3, C4, C5 that they're automatically going to be quadriplegic, but typically the higher the cervical injury, the more likely they're going to be vent dependent because their diaphragm muscles are paralyzed. So our assessment of our spinal cord injury clients. So first one, airway. Jaw thrust to open airway. Why would we not tilt? Neck injury. So even if you just have spinal stenosis, which is just narrowing of your spinal canal, if you extend or flex your neck, you can cause paralysis. And I've actually seen that in the neurosurgeon office. A patient or a client just had some stenosis, which means narrowing of the spinal canal. No injury, just all degenerative. And she actually became paralyzed because she extended her neck too much. So that's why it is very, very important for these trauma patients or these patients. So typically a spinal cord injury is going to be brought on by trauma. That you do not extend their neck because it can cause paralysis. So that is why you will see most of the time until their C-collar or C-spine is cleared, they will remain in a C-collar until otherwise noted. So you're going to protect that C-spine. Breathing. So remember, C3, C4, C5 keeps the diaphragm alive. So these patients, if their diaphragm is paralyzed, can they breathe? No, so they're probably going to need mechanical ventilation for injury, especially if there's a C3 or higher injury. Circulation, bradycardia, hypotension, tissue perfusion, we'll talk about that in a second because you can go into neurogenic shock if you have very bad spinal cord injury, which I'll tell you a client that went into neurogenic shock, and I'll tell you all about him. Neuroassessment for spinal cord injury, so motor, sensory, and reflex function. So this is when it's very important for you guys to check see if they can wiggle their toes, see if they can flex, extend their toes, see if they have sensation, because like I said, remember the very first slide, the dermatome slide? Numbness and tingling can occur based off the level of the injury. So check to see if they have any numbness, tingling anywhere. Check their motor function. You'll see, give me butterfly wings, push, give me triceps, biceps, finger, you hear it called intrinsics, and that's where you push your fingers in. And that's with your cervical injury. So you'll see the neurosurgeon do a very thorough neuro assessment for these spinal cord injury patients. And then you also want to check for reflexes, because if you have a spinal cord injury, you can either have too many, like your reflexes are very hyper-reflexia, or you can have too little. So it's based on the patient. GIGU, assess for paralytic ileus, listen to vowel sounds, palpate the abdomen for bladder and bowel distension. So this typically is not, this bladder bowel distension occurs kind of when they're recovering, and we'll talk about why this is important, especially with patients that have paralysis. Because you think they're going to be able to empty the bladder? No. And we'll talk about why, one of the complications why it's important to have an empty bladder, because we'll talk about it. Assess for and prevent skin breakdown. So do you think these patients, if they are like immobile, are they at very high risk for skin breakdown? Yeah, they can't feel it. One, they can't move around, they can't shift, they can't be like me and you and turn around when we're uncomfy. So assess for and prevent skin breakdown. And also these patients, they typically in the recovery phase, they are very kind of knows, I don't want to say malnourished, but nutrition is a very big, important aspect in these patients as well, which, nutrition correlates directly to your skin breakdown as well. So diagnosis, neurologic assessment. So that is where your neuro assessment as a nurse is key. Is this patient complaining of numbness, tingling? If a patient's complaining of numbness, tingling, and you know they have a spinal cord injury, let someone know. Don't be afraid or scared or timid, like, oh, this patient's just complaining of it. If numbness, tingling is a big sign. Can they move their extremities? Can they feel me? Can they feel what I'm doing? So your neuro assessment is very key. And I know you guys think of neuro assessment as LOC, so you've Glasgow coma scale and all that, but it entails so much more of your function, your sensation, where they can feel, where they can touch, temperature regulation. So that's what I'm talking about with your neuro assessment. You have to do a full, comprehensive neurologic assessment. Numbness and tingling, you can have injury typically to the spinal nerves, and compression, fracture, anything you have to evaluate. But the numbness and tingling can mean that there's injury in your spinal canal somewhere that needs to be noted or fixated. X-ray, it can reveal fractures. Typically, these patients are trauma patients. As we said, 50% of spinal cord injuries are motor vehicle accidents. So they will typically get the full trauma go around. So they will get a CT scan. So initially, they will get a CT scan, which is very quick. It can show your location of fracture, side compression, spinal cord edema. Typically, when a neurosurgeon shows you or they have an injury on a CT scan, they will more than likely need an MRI. The MRI gives them a more detailed picture. It shows way more detail on the spinal cord stenosis, that means narrowing. Again, it can show you where it's a very more detailed picture. So for surgical planning, now they typically would prefer an MRI, but if they're very unstable, they cannot go to MRI. So I don't know if you guys went on a road trip to an MRI machine yet, but if you have a very critically ill patient, one, you have to get a specific ventilator that's magnet approved if they're on the ventilator. Two, they only have 2 IV pumps that are MRI compatible. So if you have a patient that is on tons of medications, you have to be cautious as well, because they only have 2 compatible pumps. So MRI, those are for the stable patients, and the neurosurgeons, they're pretty lenient if they see the patient scenario and they say that the patient's very sick. I mean, they're pretty lenient about your MRI. So this right here, see this gray type matter right there? So this is your spinal cord. This is like a giant bleed, hematoma in your spinal cord. And then see how this right here is being compressed by this fracture. See your spinal cords. So some complications of spinal cord injuries. So there's 3. You have your spinal shock, which this can occur immediately after a traumatic spinal cord injury. You can have complete but temporarily loss of all muscle tone and normal reflex activity below the level of injury. So remember what I said, you cannot say a patient's quadriplegic initially. You have to at least take about 1 week before you can kind of see because of the spinal shock. Signs and symptoms, you can have flaccid paralysis. So flaccid paralysis, that just means not moving. Hypotension, bradycardia, paralytic ileus, because the valves aren't moving. It usually lasts less than 48 hours, but continue for weeks. So again, like I said, you need to let the patients recover. Typical, so reversal of the spinal shock, ASAP. So this means either removing, fixing the compression. So if a neurosurgeon sees that there is a giant compression fracture, they're going to take them straight to the operating room for an ORIF, so plates and screws. They might have to do a corpectomy, meaning take the whole spinal body out. You'll hear the terminology A-lift, which is an anterior lumbar, or E-lift, posterior lumbar. cervical, so it just depends on where your region is. So typically it's just cervical fixation. So you have a C4 or whatever the injury is, and they basically just fixate it, plates and screws in the vertebral body to stabilize the spinal canal. So if the neurosurgeon sees that they need to be stabilized, they'll take them to the OR immediately. So that's a reversal of your spinal shock. Traction, if the patient needs some sort of traction before they can go to surgery, they can do that as well. And then you also just treat the signs and symptoms that they present with, which we'll talk about in a minute. So if they're bradycardic hypertension, what would we use to treat them? Pressors, fluids, yeah. And typically with our spinal cord injuries, we will use Neo. So then we can go into neurogenic shock. So this most commonly occurs in your higher level injuries, so above your T6. So this results from injury to the descending sympathetic pathways in the spinal cord. You have loss and suppression of the sympathetic tone and vasoconstriction response below the level of injury. So let's talk about that. So you're going to have massive vasodilation, which pulls of blood into the vessels. So you're pulling into the vessels. You're going to have tissue hypoperfusion and impaired cellular metabolism. Unlike your shock states, these patients will present with bradycardia. So they'll present like a hypovolemic patient besides this bradycardia. It will be bradycardia because they lost this sympathetic tone. So this goes all into your fight or flight method. So if you lose this sympathetic tone, you lost your fight. So you lost your heart rate, you lost your intrinsic heart rate. That's why you will see bradycardic hypotension, warm, dry skin. It can present for up to 1 month after injury. So let me tell you about this patient. Well, treatment, so you're going to treat and remove the cause. So that's when the neurosurgeon will take them and surgery for the patient. So they're going to fix the broken portion, do a fusion of the vertebrae that's injured, and they'll probably go a few levels above and a few levels below. So you'll see a pretty massive fusion. Prevent cardiovascular instability and promote optimal tissue perfusion. So of course, this patient is in shock, so they're gonna have poor perfusion. So let's kind of break neurogenic shock down. And this is a big fancy tab slide, but we're gonna talk about it. So concept map for neurogenic shock. So you have your neurogenic shock right here. So you have a traumatic injury, disruption of your sympathetic nervous system. So let's talk about our causes. So loss of sympathetic tone, because if you have injury to your spinal cord, so that helps with your sympathetic tone, so you're gonna have a loss of that. Sympathetic tone, so you're losing your fight or flight, so hypotension, bradycardia, skin, warm, dry, hypothermia, why? They can't, because they have an injury to their sensory perception, their temperature regulation, they can't control it, so hypothermia. Yep. Venous and arterial vasodilation. So because you're trying to, this is your compensation right now because you have that loss of sympathetic tone, you're going to try to dilate, right, to try to increase that perfusion. Because of that, you're going to have decreased venous return because you're compensating by dilating the vessels, so it's going to decrease your venous return, which is going to decrease your cardiac index, decrease your preload. So see how these concepts are all intertwining? Your decreased stroke volume, so remember what's cardiac output? Heart rate times stroke volume. You already got a bradycardia, so you already have a decrease in your heart rate. Because of this decreased venous return, you're going to have a decrease in your stroke volume. So what do you think their cardiac output and index is going to be? Low, because of one, they don't have a very strong intrinsic heart rate, so because of this loss of sympathetic tone. And two, because of this decreased venous return, you have a decrease in stroke volume. So they have two things fighting against them now, which results in your decrease in cardiac output. And you know, if you have decreased cardiac output, decreased cellular oxygen supply because you're not perfusing, decreased tissue perfusion, and then impaired cellular metabolism. So what can we do about all this? So if this patient presents hypotension bradycardic, a lot of the times these patients, we're going to do hypothermia protocols. We're going to try to warm them up, and help with thermal regulation. So that's where you're going to see that control environmental temperature. These patients typically, when you have a trauma patient, any trauma patient, the room's going to be extremely hot. The operating room is going to be extremely hot. Comfort measures, emotional support. So with your hypotension bradycardia, you just treat symptomatically. So you treat with neo, fluid boluses. Of course, use your fluid boluses, and if that doesn't work, you would use neo. For this decreased cardiac index and decreased preload, of course, like you're going to try the fluids and then pressors if needed. You're going to monitor for kind of arrhythmias, because these patients have high risk for arrhythmias. And just some nursing, small tidbits, these patients, just DVT prophylaxis. You would not start Lovenox, but you would do SCDs or anything like that, or these stockings. These patients, if they're bradycardic, what medication other than neo and fluids? For symptomatic bradycardia, what would you do? Atropine. So you'll see a lot of neurogenic shock patients will need atropine. And the number one vasopressor for neurogenic shock is neo. Good job. All right, so do you understand the pathophysiology of neurogenic shock? You feel like you understand it? So basically it's similar to, you just lost the sympathetic tone, which is what causes everything to go downhill. But it kind of has the same concepts in that hypothermic shock does, just different mechanism of injury. But just remember, you have the loss of sympathetic tone, which causes the bradycardia, the one flush skin. So, a little backstory. I had a patient who was a MVC. He was blown out of a car. He was ejected out of a car. He did not have a seatbelt on, so he went through the windshield. He had a terrible head injury, had tons of rib fractures, and he was completely dissected at the thoracic 1 and 2. So through and through, just from being blown, I guess the impact, I think he hit head first. He went into neurogenic shock, so what were the symptoms? Neurogenic shock. Bradycardia, yeah, he was all these. So they started, what do you think they start on these patients besides Levo, which I didn't tell you because I was going to see if you guys knew. It's a medication to try to decrease swelling. It's very common. They use steroids. They'll use a steroid drip, which we'll talk about why sometimes that's not good. They use a steroid drip, so a cortisol drip, continuous, and they use it for 24 hours. This patient flown out of the windshield. And he had ortho injuries too, but he was thrown out of the windshield, had this terrible neurogenic shock from this terrible thoracic dissection, went straight to the OR, got a fusion it was like fusion from here to here. On this steroid drip, got it turned off, but he was extremely sick. So he had an open wound that ortho did not clean out initially because we were so worried about his neurogenic shock. He had steroids that exacerbated the infection. There was, he was in woods. He was in a woody area. And he had wood, so this woody area, moss type greenery was growing in the inside of him. This client, started growing mushrooms on the outside of his body. Because, and we talked about it later, it was because the steroids made the fungal infection a very nice, happy environment. He Yeah, it knocked out the drive. So when he was in shock, and it knocked out this drive. So this guy, there was nothing that could done. It was growing mushrooms, had a nasty fungal infection growing in the inside of them. So that is why you will see sometimes these patients will be on a steroid drip, but it knocks out their, they get very sick. So a lot of studies, recent studies have shown that there has been more damage to a steroid drip than there is good to it. So just kind of going out there. Wish I had pictures of that guy, but it was very bad. No, he did not survive. So your neurogenic shock versus your spinal shock, because they sound very similar, right? Neurogenic shock, you're going to have damage to this sympathetic pathway, so your sensory, that's why you have the bradycardic, in the cervical upper and thoracic spinal cord. You're going to have a loss of sympathetic innervation of the heart, so low heart rate. The key feature is your low heart rate despite low blood pressure. So, all of your shock states, you've been taught high heart rate, low blood pressure, just compensation. Here, I want you to know your neurogenic shock, you're going to have a low heart rate because you've lost that sympathetic tone. So, of course, you're going to use fluids and then neo if needed. Your spinal shock is just paralysis that can resolve. It's just you're in a shock state. Yeah, so you're not going to see a change in your vital signs. You're just going to see the spinal shock is just paralysis. So you're going to just see flaccid muscles that could last for 48 hours. And then hopefully when you fix the spinal column, have surgery, do whatever that needs to be done, the spinal shock will resolve. Again, remember I said that is why you have to assess if a patient has deficits 1 week after, because there's been many times where the neurosurgeon will come into a patient's room or client's room and say, hey, this patient is paralyzed, and then a week later, they're doing everything we wanted them to. So that was spinal shock and not technically paralysis. And just because a patient is deemed paralyzed within an acute recovery, don't not treat them, don't not assume that they can't regain function because of the spinal shock. All right, do you guys understand the difference? So neurogenic shock, you actually have vital signs are in a shock state. Spinal shock is you're just paralyzed from the injury, and it should go away within 48 hours. And then our third one, autonomic dysreflexia. So remember, what did I talk about? We're talking about this full bladder, or if he has a massive poop he needs to take. We'll talk about that. So this is a life-threatening medical injury. This occurs in your clients with an injury at or above T6. So remember, all these complications typically occur in your higher spinal cord injury. It is caused by massive sympathetic response to a noxious stimuli. So what's some noxious stimuli that you think? It's very discomforting. So if this patient has a full bladder, restricting clothing, if they have a fecal impaction. So these patients can't empty their bladder. Could you imagine having 1 liter of fluid in your bladder, being a spinal cord injury patient, and then going into autonomic dysreflexia because of this sympathetic response because of a full bladder? So these patients will typically complain of a severe throbbing headache because they have this massive sympathetic response, this massive fight or flight. They feel like they need to go fight someone. Hypertension, bradycardic, so it's kind of similar. Bradycardia, so similar to your neurogenic. Flushing, diaphoresis above the injury, and kind of hail below the injury. So immediate injury is needed to prevent cerebral hemorrhage, seizure, and acute pulmonary edema. The majority of these patients, if you just straight cath them, digitally disinfect these patients, take off whatever's restrictive, they'll resort back to normal. So that is why these patients will typically, once they get through the acute phase, will be on a bladder and bowel management. meaning that you will bladder scan them every 4 hours or per your principal hospital or wherever policy you're going to be, but you're going to bladder scan them every 4 to 6 hours, see if they're retaining any urine, and if they are, you're going to straight cap them. And some protocols even make you just go ahead and straight cap every 6 hours because you know they're not going to empty their bladder. Same with this fecal impaction. These patients are going to be on a bowel management regimen. So they're going to have the Colace, the Miralax, some stuff to help them go to the bathroom because we want to avoid this automatic dysreflexia. Because this is something we can prevent. If they are hypertensive, of course, and then you would treat your underlying cause. So if they're hypertensive, of course, give them an antihypertensive medication. Typically, I'm going to be careful with labetalol because these patients can cause labetalol can cause bradycardic, so you'll see hydralazine used in these patients. So this is something we as a nurse can prevent. So that's why you're going to be on this strict bowel and bladder management when you are assessing their bladder and bowel function and making sure they're going to the bathroom. So you'll see labetalol and hydralazine ordered on your med list. But these patients may present with bradycardia, so you don't want to give labetalol if their heart rate's bradycardic. So you'll typically see hydralazine being given if they need an antihypertensive, if they're bradycardic. All right, so autonomic dysreflexia, spinal cord injury, a T6 or higher. So notice, like, if you have a higher injury, you're more at risk for all these complications. Restrictive clothing, so like if you just have, so I don't know if you guys seen the cardiac chairs, but even that belt on the cardiac chair can be considered a restrictive type of clothing. Pressure areas, fecal impaction bladder. So these are things that we can prevent. These are, so you're going to have, because of the injury, you're going to have these vasodilation above, vasoconstriction below because of the injury. And that's just a helpful picture to help you. What? Yeah, well, their body actually starts, their body goes into this, because your body goes into a massive sympathetic type fight or flight response because of this increased pressure. So these are things that we can totally prevent or avoid. Here is just another cause. So there's 3 F causes: full bladder, fecal infection, funny feeling with skin, and then your assessment. Just some more images to help you with your studies. Medical management of spinal cord injury. So now we've kind of talked about the mechanism of injury. We've talked about what some complications, the 3 complications that can occur. So now we're going to talk about the medical management for spinal cord injury. So of course, our first one, we're always going to do our ABCs, right? And so let's talk about some pharmacologic information. So prednisone, remember what I said. They typically give it within first 8 hours. This is physician driven. Typically, there's been more studies that shows that it causes more harm than good in these patients, and it doesn't decrease. So the purpose of this is to decrease cord swelling. But it shows there's been more studies now. I actually was reading one last night, but there's been more studies that show that a prednisone drip is more damaged than good. And so you've actually seen a decrease in this drip being used in the hospital for spinal cord injuries. Of course, there's ongoing research, and of course, your older physicians, your older neurosurgeons that kind of have their old school ways, you might see this, but I don't think I've seen this be done in 2 years. I haven't seen it been given or administered in 2 years. And then, of course, fluids and vasopressors. So your fluids, because they're in this shock state, neurogenic shock, right? We're going to replenish your fluid. That's your first line of treatment for all shock states. Fluids, vasopressors, which is NEO. So Levos for sepsis, NEO, you're typically see in your spinal cord injuries. You're going to be so smart when y'all go to ICU and y'all just going to know it's NEO. And it's going to correct your low blood pressure and increase your cardiac output. Surgical, so unless you guys become first assist nurse practitioners or go to PA school or something. Being in a spinal cord surgery is very fun, but the neurosurgeon will then stabilize. So they will see the scan and they will stabilize. So they'll do a fusion, they'll do a corpectomy, they'll do whatever they need to do. And we'll talk about some type of plates and screws that they can place in a minute. If they have disrupted ligaments and tendons, the vertebral column unable to maintain alignment, they'll fix the alignment surgically. That's a surgical intervention. You as a nurse would just prepare for surgery, so that's get consent signed. CHD, make sure they're prepared for surgery. Non-surgical treatment, so treatment for choice if spinal cord injury is stable. Of course, you're going to see your C-collar, your Vista collar, skull tongs, halo vest for your cervical injuries. And then if you have a thoracic or lumbar, you will see a TLSO or an LSO brace. So your TLSO brace is for your thoracic injuries. Your LSO brace is for your lumbar injuries. And the physician, if the spinal cord injury is stable, they will just order this TLSO brace or LSO brace, typically when they're out of bed. And they gotta wear it for 4 to 6 weeks. And that's only if the spinal cord injury is stable and does not need surgical intervention. All right, so C-collar, if you guys don't know what this is by now, we're in trouble. This is your C-collar brace used to support the neck. That lovely neurosurgeon I worked with, he told me that he asked me a trick question. He said, what does a C-collar do? And of course, being me, I was like, oh, it maintains your cervical, like it maintains alignment and all this stuff. He said no. He said it's really so they can't move their neck. I said, really? And he said, yeah, because how the position is of your C-collar, they can't move their neck, so of course it's going to stabilize. Oh, I thought it was funny. So it's typically placed on scene, so the patient will always have C-collar on until their C-spine is cleared by a physician. Can you as a nurse clear a C-spine? No. What if you see, oh, their scans were fine. I'm going to take this off. Can you do that? No. You have to have an order by a physician or a nurse practitioner to take your C-collar off. Typically, if the cervical spine is stable and intact, there's no disruption of the ligaments or tendons, they're typically wear these for 6 to 8 weeks. These are very uncomfortable for patients, so you just have to remind them on the purpose of why they're wearing them. Of course, you Velcro them on this side. The height of the chin support can be adjusted with this knob right here. So where my mouse is. Right there. So that's for your cervical injuries that are stable and don't need surgical intervention. These patients typically don't have deficits. Cervical traction with these tongs. So these typically are used for preparation to surgery. So they'll place these. So they're these little burr holes in the side of the cranium, and they'll place these screws in, and they'll put the weight right here. Right here. So it's inserted into the skull through burr holes and connected to traction weights. And it immobilizes the fracture sites and realigns any dislocation. So say there's a patient that needs surgery, but they needed some kind of try to realign the spine prior to surgery to make it a little easier on the surgeon, they'll place them in traction. It can be placed at the bedside using local anesthetic, so they'll just use some lidocaine for these burr holes, and then they'll just, I don't know if you guys seen it, but they just drill into the brain, or not into the brain, they'll drill through the skull. Can you, as the nurse, mess with these weights? No, typically it's a physician-ordered, physician or nurse practitioner driven. You as a nurse will just make sure that the patient's aligned and comfortable, but you will not manipulate these weights whatsoever. I actually have never seen one of these. Yeah, this is old school. Yeah, I was gonna say, I know Dr. Altman's seen it.
Oh, really?
I've never seen this. The only time I have seen this occur is in the operating room, and it was very quickly. That they placed them into traction quickly, and then, so they had them into traction and then surgically intervened. That's the only time I've ever seen it. I've never actually taken care of a patient. So Dr. Altman can probably answer more questions about this.
Usually when they use this, they use it in the preliminary,
Yeah.
in a lot of swelling until we can get a halo place.
Yeah, we'll talk about
They like this for 2 days. That's why when you look at those weights, you gotta be careful with this. That's not good.
Yeah, the majority of these, the only time I've actually seen traction being applied is right before they're about to do surgery, and they'll have them traction just to kind of help with the alignment of the spinal cord. So I've actually never seen it bedside for multiple days. I have seen a halo though, multiple times, we'll talk about that in a second. And then this roto rest, which Dr. Altman can talk about this, because I have never seen one of these before. I actually have never heard of one of these before until this lecture. No, it is not. So the reason for this bed is just to maintain spinal column alignment. So it works like the rotoprone, as in you're like moving from side to side. You do not flip upside down. And the purpose of this roto rest bed is to maintain spinal column alignment. I'm sure this is used pretty regularly and I bet it's used a lot in spinal cord rehab or spinal cord type hospitals. I've never seen it. But it does provide that constant turning motion to reduce pulmonary and skin breakdown. But it's not a rotoprone bed, as in it doesn't flip you like a rotisserie chicken. And then our good old halo. So you will typically see these halos in a high cervical injury patient. If you have an adductoid fracture, which is a fracture in the neck, you will see this. And if you have a ligament injury, so a ligament in the neck injury, you will see this halo. It is used once the spinal column has been realigned. So I have seen the traction being applied right before surgery. They do the surgery and they place the device. So you have a metal ring. So the metal ring surrounds the head. It's secured to the skull with two anterior, two posterior screws. Steel bars anchor the screws to vest. So you have these being going around your head, and you have these steel bars connected to your vest. To provide cervical immobilization. They typically have to wear this for 6 to 8 weeks. Could you imagine? It allows the client to ambulate and participate in self-care. So it's kind of like an X-Fix. So have you guys seen an X-Fix where on the leg, where they have that external device? This is kind of the similar mechanism. It's trying to allow the patient, it's providing that cervical immobilization while trying to give this patient as much freedom as possible. There is a wrench that you will have at all times. You will have it kind of like you have an obturator for a trach, kind of how you have wire cutters for a closed jaw. You will have a wrench taped to the vest in case of an emergency. Can you do chest compressions on this vest? It is hard. Does it?
Yeah, it's like in the, okay.
Oh, that's so nice. I haven't seen the new ones. Well, that's nice. So I guess they recreated these because they knew how terrible, if you're in a code situation, how terrible it is to get a wrench out. Be like, hold up, let me hold these chest compressions. Let me unwrench you real quick. So always keep your wrench taped to the vest in case of emergency, unless you have these new fancy, which I'll have to see them. So it's important for a skin assessment in these patients. Assess skin under the vest, ensure that there's going to be like a sheet covering underneath, so you want to make sure that sheet covering is touching the skin and that the actual hard part's not breaking into the skin. Typically you'll see that on the shoulders, so you want to make sure that's happening. And then you're going to have perform pin care in the posterior and anterior portion. So like I said, these are typically used in your cervical fractures, if you have an adductoid fracture, or if you have a ligament injury. Typically, if you have a C1, C2 fracture, adductoid fracture, ligament injury to your neck, you will get a halo placement. Unfortunately, you will see sometimes like 80-year-old women that had a fall, they broke their neck, and they'll have to wear one of these, and it's really sad. It's very sad because this really is crushing, especially for an 80-year-old female. All right, so this is all management for low, like if the spinal cord injuries are stable and they do not need surgery, right? So this is what your TLSO brace. So your TLSO brace. So this is a hard shell cast. This is what you typically see as your TLSO brace. So this, you will get a physician order if there is no surgery warranted. There's just some type of fracture in the vertebrae and the physician thinks that they need a TLSO brace. This is all physician driven. They will order a TLSO brace when out of bed. Typically, they have to wear it 4 to 6 weeks, but they will follow up with the neurosurgeon once they get released, and they'll evaluate further. But typically, these are worn out of bed only, unless otherwise indicated or ordered. And then you have your LSO brace. So this is for your lumbar region. So if you have an injury to the lumbar. What if you had a T12 or L1 injury? Which one do you think you probably would? They'd probably order your TLSO brace. So your lumbar is for those lower lumbar that if you don't have enough. Typically how they order these is if the level above goes into the thoracic region, they'll just go ahead and order a TLSO. But if it's like an L3 and you're above is an L2 and you're below the L3, they order this LSO brace. And typically it's going to be this brace right here. These are the hard shells that you might see in the hospital. Nursing considerations. So we're going to assess these patients frequently. Immobilize and stabilize, that's very key. So initially these patients are going to be, you're not going to want to take off the C-collar and be moving these patients. Head of bed flat, log roll. What does it mean to log roll? Log roll a patient. Yeah, so they are completely stable, like laying like a log, and you do all the work. So that means you're going to have someone holding C-spine, and if you're holding C-spine, that means you're in control. The nurses will be like, C-spine, do your countdown, 1, 2, 3, and you as C-spine is in control of it all. Until otherwise cleared, you're going to have C-spine precautions with the C-collar, and then it's cleared, you can take it off, and they can do whatever. Respiratory system is greatly affected, especially with your higher spinal cord injuries because of C3 and 4, C3, C4, C5. Try to keep it out alive, right? These patients often have difficulty clearing secretions, especially with a higher level of spinal cord. So you'll see these patients have to get bronched multiple times during admission. You will also see these patients have difficulty with respiratory, and these patients sometimes will end up in the rotochrome bed or some type of higher mechanically ventilated. It's all patient specific. If intubated, suction with caution in acute phase because of the vagal stimulation. What's the vagal stimulation? Yeah, so it can lead to cardiac arrest. Monitor for signs and symptoms of complications. They are serious, so even the numbness and tingling can be a concern. So I don't want you to ever, if a patient's complaining and you know they have a spinal cord injury, I don't ever want you to take numbness and tingling lightly because that can be a sign that there's cord edema, there's injury to the cord. Bladder and valve retention. So this is for typically after your post-acute phase on these patients that are paraplegic or even definitely quadriplegic. You're going to prevent the UTI, so you're going to empty that bladder, straight cath, fecal disimpaction, and there will be a order that will be driven by the nurse practitioner or physician for strict bladder and valve control. You're going to turn these patients every 2 hours to prevent pressure injuries because, like we said earlier, they have very high risk. DVT prophylaxis. Are we going to want to start Lobanovs initially on these patients? No. So we're going to reassess if there's no bleeding and they're showing no signs of bleeding, they're typically start DVT prophylaxis. Typically, if they don't have a head bleed, which a lot of the times these patients have head bleeds, but if they don't have a head bleed and they have spinal cord injury and that's it, they will start anticoagulation 18 hours post-op, as long as there's no other indications that would contraindicate DVT prophylaxis. But we can, you as a nurse, you know there is other DVT prophylaxis, TED-HOs, SCDs, all those things. Emotional support due to loss of functional ability. I don't know about you guys, but I'm a pretty active person, so if this occurred to me, I'd be pretty heartbroken, and I feel like you guys would be too. So that is why it is very important for you as the nurse to kind of just be there for your patient as well, because it is a very hard time. You will see a lot of these patients will actually be started on some type of antidepressant medication in the kind of rehab facility. All right, so I'm going to show you this video of how to log roll because I think it's a very important skill. All right, care of your spinal cord client. So paralysis, you're going to assess your urinary bowel because what syndrome can cause if you have a full bladder? Yeah. Respiratory depression airway, level of injury. Your higher level of injury can cause diaphragm injury. Assess your neuro and LOC, so that includes both sensory and motor function. Log roll the patient, especially if they have a cervical injury. You're going to monitor circulation. You're going to try to prevent thrombus because when you have injury to the spinal cord, you are at increased risk for a DVT being lodged out. Encourage protein and fluid. Remember what I said, these patients have an increased risk of skin breakdown. They also have an increased risk of malnutrition. And you know those two concepts go hand in hand. And then your dermatology, so that page from the very beginning, it kind of helps you. I mean, it is spot on. If you have an injury to the T1, you're going to see those dermatomes being directly infected if it's a true T1 fracture. All right, so this goes on to talk about the rehab phase. So initial management, that's kind of what we've been talking about. Those patients will hopefully go to a long-term facility called Shepherd's, which specializes in spinal cord and neuro injuries. That's kind of the goal. But there's other long-term facilities or rehab facilities that they can go to. You want to encourage pulmonary toileting. So what is pulmonary toileting? What does this include and involve? Turn, cough, eat, breathe. What else? And an incentive spirometer. How often do you want them to be using that? Pretty frequently, I always tell my patients every commercial break. Oral care and hygiene. Why is that important? Yeah, so there's been tons of studies that if you don't do proper oral care or secretion to get their secretions out, it drives your rate of VAP, so ventilator-associated pneumonia, up. So that's why that's important. Out of bed if able. So remember what we said about our TLSO or LSO braces. If they have those braces ordered, they can get out of bed as long as they have those braces on. And then sometimes ordered by the HCP breathing treatment. So you'll see your albuterol treatments. You'll see cough assist and Fuller valve. So that's your pulmonary toileting. Chest physiotherapy. So what is chest physiotherapy? Yeah, so it's like cussing. It looks like they're beating the chest. So if a patient has this chest physiotherapy on and it looks like they're in BFib in the monitor, it's probably not real. SCDs to prevent DVT. So you're going to want these patients to have SCDs, especially if they're they have any of the plegias. Facilitate range of motion. So these patients will get physical therapy, occupational therapy from the get-go. Mobilize client to chair as soon as possible. So once you get that order from the physician that they're cleared to get out of the chair and you have your brace, if ordered, then get them up as soon as possible. It helps with muscle engagement. Turn assess your patient. Skin frequently to prevent skin breakdown. We've already talked about that. That's been driven through you guys. Nutrition, they're going to need an increased need for calories, protein, and fluids. Why do you think this is? Yeah, they're healing one, so they're gonna have an increased metabolic demand. So you're gonna wanna increase their calories, protein, and fluids. Prevent contractures and foot drops. What is that?
Put their shoes on.
Yeah, so sometimes if you don't see the little boots placed on the ordered, you'll hear the physician say, or tell the family, bring in a pair of his or her favorite shoes, and prevents foot drops, it keeps them stabilized. Provide emotional support, talk about the disability. You don't ever want to sugarcoat these injuries to these patients. So if they're a high quad, you don't ever want to say, and you know you've had the 1 week initial and you kind of know they have a high level of injury, you don't ever want to say, oh, you'll regain it back, because that provides very false hope. You want to be kind of strict, and you want to tell them from the get-go what their initial injury is going to be, because if you give them that false hope, it's very disheartening when they can't reach that point. Encourage rehab after hospital discharge. The majority of these patients will go through some type of rehab. Encourage participation in community support groups. So there's a ton of resources for these patients. And then educate about potential complications. So those are what we just talked about. Neurogenic bladder training, we already talked about what the bladder training is, that you're going to have that protocol driven by your NP or physician, and then it's nurse driven. So that's bladder scanning and straight cathing regularly. And then you're going to have bowel training as well, so increase fiber, you're going to maintain hydration, have them on those medications, so your stool softeners, your Miralax, medications like that. And then you might have to even disinfect the patients. All right, question.